welcome everyone on behalf of the Northwest Mental Health Technology Transfer Center. Welcome to our webinar focused on the journey to use medications optimally to support recovery with Dr. Patricia Deegan. Today is part 2 of a 2-part series on this topic. If you want to catch up afterwards and go to part 1, we'll share the website that you can access that on. We're grateful so many of you can join us to learn more about this topic, and we're really excited to have some of the conversations with you all. Will allow some time for some facilitated discussion. My name is Maria Monroe DeVita. I'm on faculty here at the University of Washington and work with the Northwest MHTTC, and I'm joined today by my colleague, Dr. Akansha Vaswani Bai, who will be facilitating today's discussion with Pat. So I'd like to start with our land acknowledgement. The Northwest MHTTC honors the many cultures and lands across our region, spanning Alaska, Idaho, Oregon, and Washington. We want to acknowledge that the Northwest MHTTC, based in Seattle, sits on the traditional land of the Duwamish and Coast Salish peoples, past and present. We honor with gratitude the land itself and the people who have stewarded this land throughout the generations. So a little bit about our MHTTC network across the country. It's a nationwide network that is supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA. Our purpose includes disseminating and implementing evidence-based practices for mental health issues into the workforce. The goals of the network include supporting mental health-related evidence-based practices, heightening the awareness, knowledge, and skills of the workforce, fostering regional and national alliances, and providing and connecting you to free training and technical assistance. Now a little bit briefly about our Northwest MHTTC in particular. We're based at the University of Washington in the Department of Psychiatry and Behavioral Sciences. We provide training and technical assistance in evidence-based practices to Region 10, which includes Alaska, Idaho, Oregon, and Washington. Our area of focus is evidence-based practices for serious mental illness issues such as psychosis. However, we also provide training on a variety of topics, including integrated care, suicide prevention, diversity and equity issues, school mental health, peer support, trauma-informed care approaches, and others. Our target workforce includes behavioral health and primary care providers, school and social service staff, and others who work and have the potential to improve behavioral health outcomes for individuals with or at risk of developing serious mental illnesses. And we fulfill our mission through live events like this webinar that we also record and post for later review asynchronously, virtual learning opportunities and communities, free self-paced online resources, newsletters, and our resource library on our website. And connection to other MHTTCs who offer training that we may not have expertise or provide. So to find out more, we'll make sure that you have access to our website after today's presentation. You can also sign up for our newsletter. Its intention, our intention always to be mindful of using language that promotes recovery and culturally appropriate terminology. So we encourage in today's webinar that all clinicians and people participating use language that demonstrates respect for a person's dignity and worth. It's consistent with recovery-oriented practices and promotes treatment environments that foster respect, dignity, and hope. Next, I would like to talk a little bit about logistics. Due to the large audience, all attendees are muted and not appearing on video, and the chat box will be visible. So whatever you post in there, if you put it to all participants, they will see it, as well as the Q&A box if you have a question. We'll talk a little bit about how you use those different features in a second. The presentation is recorded, and the recording and slides will be made available on our website in a few weeks. You'll get an email from Zoom with a link to where we post them. And you'll receive an email within 2 weeks on how to access a certificate of attendance, but there are no formal CEUs. If you're experiencing any technical issues, you can use the chat, send it to our MHTT staff and they'll assist. And then there will be some times when Pat asks you to share a response or to provide a comment, and so you can put that into the chat as well. Otherwise, if you have a question, then you would go to the Q&A box, and we'll be monitoring that. And we'll have a couple of different times that we'll kind of go back to the Q&A box specifically, but for the most part, Pat will be continuing to, present for a period of time before we kind of stop for a moment to go back to that Q&A box. So for questions, post them there. For comments, put those in the chat. Lastly, your feedback is crucial to our work, so we'd really appreciate your response to a short survey after this session. Our team will share that link by the chat box today, and we'll send a reminder by Zoom tomorrow. We're required to, by SAMHSA, to conduct the survey, and we really appreciate your feedback too, because it really helps us to guide future training like this and helps us to kind of keep great topics going as we move forward. SAMHSA sponsors this work, but does not reflect any official position on this content. And now, for the most important part, I'm really happy to introduce Dr. Pat Deegan, one of my heroes in life and work. Pat Deegan's mission is to help and activate and empower mental health services users in their own recovery and to provide peer supporters and clinicians with the know-how to support people in their recovery journey. She's uniquely positioned to fulfill her vocation because she was diagnosed with schizophrenia as a teenager, went on to get her doctorate in clinical psychology, and today leads a company run by and for people in recovery. She's a thought leader in the field of mental health recovery, has numerous peer-reviewed publications, has held a number of academic appointments, and has carried a message of hope for recovery to audiences around the world. In addition to her work on the CommonGround Program, she consults with OnTrackNY and has helped the team at the Center for Practice Innovations develop an innovative model for engaging young people under the NIMH RAISE Study. This model is now being adopted nationally. So I'm going to turn it over to you, Pat, without further ado, and welcome to everyone. We're excited to learn more from you today.
Thank you so much, Maria. Hi, folks. I know I can't see you, but I do believe you're there. It's always important to say that. Yeah, so it's a pleasure to be here today. And I just want to start out, as I often do, just thanking you for what you do. That I think historically, those of us who are diagnosed with serious mental illness have been a devalued and marginalized people. And there's a certain contagion stigma that goes with working with people who are socially devalued. And I just want to say that I see many of the good things that you people are up to across our country, and that it matters, and that very often that we show up at work, and too often we don't hear. Thank you for what you do. It does matter. It matters profoundly in the life of my peers, and always we can all do much better, but I want to thank you for what we're doing now. And I'm hoping that today's presentation will help you become even better at what it is that you do. And just a thought for the day. I've been really kind of cogitating on this. You know, my mom is quite elderly now, and it's recently been admitted to a hospital with a urinary tract infection. And one of my sisters was there just keeping an eye on how things were going. She has dementia and stuff like that. And anyway, she was talking to the hospitalist who was attending my mom's. And my sister said, can't you focus on the whole picture here? He said, no, I'm treating her urinary tract infection. And I said, gosh, isn't that something that when we focus on the illness, we miss the person, right? And one of the things, that I do memes about and stuff is that illnesses don't recover. People do. And once we reduce a human being to being a disease process, to being a disorder, there's no one left to do the work of recovery, right? And so the art of doing recovery-oriented practice is to recognize that we work with people, not with diseases, and that we provide treatment for, we provide care for, not diseases, for people. And as soon as we can make that shift, everything changes. That is the foundation of good practice. So let's keep that in mind today as we move through these slides. Okay, so I'm going to share my screen, and we'll get down to it. Okay. And all right. Oops. I need to go to full mode. Sorry. All right. Medication empowerment beyond medication education. I've changed the title from what was maybe in your brochure. This is what I'm calling this piece of work. This is the second webinar. In the first one, we looked at some of the challenges on the journey to use meds optimally. Today, we're going to look at some more of the challenges on that journey. But my new name for this important work is medication empowerment. And medication empowerment is a guided process of identifying and working through the challenges that are associated with using meds in order to help me get the life that I want. And this reframe is very important. As I discussed in our first webinar, it's very important because we recognize that using medications is more than simply taking prescribed medicine on schedule. If that's what it was about, it wouldn't be that challenging, right? Rather, using meds is actually a journey that takes place over time. And for some of us, takes place over the course of the better part of our lives. And what I love about this new frame, using medications as a journey, is that it helps us as clinicians shift the focus from getting people to take meds to supporting people through the challenges of using medications optimally to help them get the life they want. And that is an extremely different framework than getting people to take meds, which, as we all know, so often ends in futility. So last time we met, we discussed these challenges. We discussed the challenge of passivity and waiting for meds to cure me. And we talked about, I don't take my meds because they're not helping me. So how does one identify if meds are helping or not? We discussed the trade-off challenge, trade-offs between the health risks and the benefits of using this medicine, or the trade-offs between the wanted and the unwanted effects of medications, right? And also challenges around motivation. My husband wants me to take the meds. I don't think I have any motivation to take them. So finding personal motivation. And now ask ourselves, what do we actively do to support people in meeting these challenges, right? To help them move through these challenges so they can get to this place that I describe as optimal use of medicines, because optimal use of medicine means so much more than simply taking meds on schedule. It means so much more than simply being compliant or adherent. Optimal use of medicine means I know my personal motivation for using meds. So when it gets tough to use the meds, I kind of grit down and I say, okay, but I remember my motivation for using them, right? Or that I have a sense, my own sense, that meds are helping me. Sure, my mother might like me when I'm on the meds, but I need to believe that they're helpful to me. Well, today we're going to cover the remaining challenges on this journey. And this journey is not linear. And a person can have achieved optimal use for a while and things change, and all of a sudden they're experiencing a trade-off challenge again, or they're experiencing a motivation challenge again. So today, here are the challenges that we're going to cover to complete this two-part course. We're going to explore the exploration challenge, which is the challenge of figuring out how best to manage our mental health challenges. It's the challenge that involves figuring if and how to reduce or to discontinue meds, or exploring the use of cultural or complementary approaches to wellness, and what works best for me, exploration. Then we're going to explore the self-medicating challenge, and I know you all know a lot about that one. The challenge of addressing if and how substance use is affecting my recovery. Medication fatigue challenge. This is the challenge that can go with having had many trials on medications that aren't particularly effective, We know that about a third of people who are prescribed antipsychotic medications have no discernible beneficial response. We find a suboptimal response, right? So that can be an incredible challenge when I find myself perhaps on too much or too many different medications that don't work particularly well for me. There's another challenge, which is the implicit racial bias. Now, this is a challenge for people of color, and it's the challenge of trying to get appropriate individualized care with white clinicians who may be experiencing their own implicit racial bias when working with an individual. And then we will learn about the redefining self challenge. And this is a really powerful challenge, I think, and one that I think you'll be pretty amazed to learn about, right? So just to let you know how prevalent these challenges are, I'm not talking about a unique experience. So many of you know that I've developed a software program, a web application called CommonGround. And in the CommonGround software, individuals come into a standard psychiatric medication clinic. It could be an ACT team, it could be a clinic. They instead of waiting in a waiting area, they meet with a peer specialist who helps them prepare to participate and use the CommonGround application to let their doctor know how they're doing since the last appointment. So I decided as part of that experience, people have an opportunity to say what their concerns about their prescribed medications are. So I looked at 40,697, culled this from our database, between, and all of these people are in public sector mental health who qualify for, Medicaid reimbursable services. And I looked at the point in time where they did their first health report. So this is at their first time using the CommonGround software. And I looked at the years August 2007 through June of 2021. That's a lot of people, right? The number one concern across that very large number was that I don't find the meds to be helping me. 38% of over 40,000 people. Well, if you were at the first webinar, we discussed very specific things that we could do as a team to support people upstream in knowing whether or not meds are helpful, discovering that together as a team, right? Side effects, 25%, health concerns, 23%. I'm not motivated to take meds, 15%. We don't have to let this slide by. There's more we can do. And that's what this course is about. So I know I've been distributing a whole lot of worksheets, and I don't particularly like worksheets. And I'm under no illusion that we whip out a piece of paper in the middle of, but what a worksheet it does do is a worksheet gives you a method. Okay. And we always do a worksheet with an individual. We never just hand it to them. And the worksheets are in English and they're in Spanish and they're form fillable and they can be used, right? During telehealth visits because they are form fillable, right? And we work together, and together then we can discover what is my personal motivation. We can discover how and if medicine helps me. So we don't have to let this go on. People are telling us loud and clear, I'm exploring other alternatives than psychiatric medicines. Okay, point made. I feel passionately about it though, honestly, because I think we can do so much better. And it's such an important thing. Meds can be helpful for many of us, not all of us, but for many of us. But I think we can only get to optimal use if we can actually become skilled in supporting people through these challenges. And in order to do that, I want you to remember that we looked at the self-report, my concerns about medicine. And I asked that you think about how to embed this little self-report, 13 items in your care pathway. And that there's some kind of routine trigger for when we complete this worksheet with an individual. Are you thinking about stopping or lowering your meds? Are the meds helping you? Are you concerned about being racially profiled by a white mental health professional? Are you tired of taking meds? Are you exploring other healing strategies, cultural strategies for healing? If so, we can support you in that. That's not a private thing. We can do that together as a care team. Embedding this in your care pathway in a way that you can stay upstream of people's challenges makes really good sense, given the prevalence of these concerns. And like I say, these concerns are dynamic. And what that means is that I may be cool the first 6 months ago, but all of a sudden, a new person has come into my life and I want to get sexually active. What has been is that sexual side effects haven't been a big concern. Now they are. That's the dynamic nature of these challenges. Okay. Let's move on now to our new challenges today. So I said we were going to do an exploration challenge. So this is Van. And Van said, I just wonder what I'm like when I'm not on meds. You know, I think the weed was laced with something and that made me freak out. And it was like a phase and I'm over it now. So this is important because it's indicative when we hear something like this, we're hearing that Van is beginning to experience an exploration challenge and that he's grappling with these questions. Maybe it was the weed, it was bad weed, maybe I'm over it. It was temporary. It was a phase I was going through. We hear this all the time, right? And there's a way to engage Van, so he's not all on his own, needing to or thinking that he needs to go off to see if it was the weed or whatever he's thinking about doing. This exploration challenge also sounds, I find typically that there are 3 categories: cultural and complementary explorations. I'm looking to reduce or discontinue the meds altogether. You can count on that being for like 99.9% of people. And also questioning the diagnosis and my need for treatment at all. That can also be a form of this exploration challenge. And here's what it might sound like. I think a sweat lodge would work better for me. Or I heard that St. John's wort and eating vegan can help me. What if I feel fine now and I'm ready to go off meds? I take an aspirin when I have a headache. I take an antipsychotic if I'm having psychosis. I feel fine. The meds are too heavy. I want to go down on them. I think this is about trauma, not psychosis. I'm having a spiritual emergence. I'm not mentally ill and I don't need meds. So there are key questions that we can use in clinical practice to stay ahead of the exploration challenge. Right at the outset of collaborating with a person around their journey to use meds optimally, when we're prescribing a medication, we can say to the person straight up, if you're like most people, at some point, you might wonder if it's time to go off meds, if it's time to question your diagnosis. Is it time to explore natural or traditional healing? And if these questions are coming up, if these ideas are coming up, please don't keep it a secret. Okay? We can talk. We can figure this out together. And the analogy I use is that we can be co-explorers. We can explore this together. It is not taboo to think these thoughts. This can be between us and we can work on it, right? So use those key questions when you're hearing the kinds of exploration things that people say. Now there's a very particular situation in here, which is, as we all know, extremely challenging. Here's Greg. And Greg is basically saying, I don't need meds and I'm not mentally ill, right? And that also is part of this exploration challenge, right? So that can be, another dimension of this challenge. So what can the team do to support people who are saying the kind of thing or acting out the kind of thing that Greg is saying? And I think this can become really tough because very often people who are in this type of exploration challenge, they do things like abruptly go off medications only to become very acutely symptomatic again. And, sometimes folks are even ending up in places like a jail or homeless or back in the hospital. And it can tear at us, right? It can be like, don't do this, right? And I feel that frustration sometimes. And it's also really just sad especially if we see a pattern unfolding over time. So one of the things that we sometimes do is we call it anosognosia, we call it lack of insight, and I don't find those particularly helpful terms. And often we're forced to make really tough choices about involuntary treatment in the community as well as involuntary treatment in hospitals. And I'd be lying if I didn't say these are really tough situations. So it's not like I've got a magic elixir, like we can but I do have a place to start. And I'm not sure if you've heard of this. So let's talk about Greg for a sec. Greg is a 20-year-old heterosexual, cisgender, young adult, diagnosed with early psychosis. He lives with his mom and two younger siblings. He is enrolled in a coordinated specialty care program. He's got 4 hospitalizations in the last year while enrolled in his program in the CSC. And during each inpatient stay, he was medicated over objection due to the fact that he was rejecting all medications in the hospital. Greg discontinued meds within a month after discharge each time, right? So now he's in his 4th hospitalization, and the team is petitioning for involuntary outpatient commitment. And the team's perspective is that meds are really helpful. And specifically, the team can point to the fact that they help him communicate more effectively. He's less verbally aggressive with his mom. He's able to focus and to work with a supported employment, an education specialist on his goal of completing his GED. All things that are pretty important to Greg. And he says he doesn't need the meds because he's not mentally ill. He had a very bad experience with weed at 16, and he steered clear of it ever since. But he uses alcohol when he can, but there is none in the home. And he has no independent income to purchase weed. To purchase alcohol either. So exploration challenge. And as I said, I don't find insight a particularly helpful, help him gain insight. What does that even mean? Like kind of good luck with that. I don't know. It's very vague. I know of no method. Some people, anyway, the thing I don't like about insight the most is it basically puts us in a conflict with the person. You don't have insight. I have insight. What I know is right. What you know is lacking insight. And we're like this. And it doesn't seem to really go anywhere, right? It doesn't seem to go anywhere. So I suggest steering clear of insight as a construct. The next thing I recommend is that we sit down with Greg while he's still in the hospital, and we look at that self-report and we hear from Greg, what are your concerns about meds? Are you not feeling motivated? Do they not seem to help you? And really then begin to work through the associated challenges while in the hospital that he's identifying, right? So if it's a motivation issue, there's a worksheet for that, right? Because you attended this course, okay? I think another thing that we can do is what I call balancing my beliefs and values. We can help him think about his beliefs and his values. And of course, there's a worksheet for that operationalizes what I'm about to tell you. So what are beliefs? Well, most essentially, beliefs are assumptions that come from our family and from our culture. Those are beliefs, and they're malleable. We can change beliefs, right? Values, on the other hand, are principles by which we aspire to live our lives by. So values are principles by which we strive to live our lives. Principles are things like, the principle of freedom, the principle of a young man should be supportive of his single mom, the principle of I believe in helping my community, the principle of nonviolence, what your principles that you try to live your life by. So here's Greg, and his big dream was to be, a first responder in his community, and helping people in the community was a really big value that he lived and wanted to live out his adult life by. But he also, this is a true story, by the way, this was somebody I knew, and he also struggled with his mental health challenges, diagnosed with psychosis early on. And he believed personally that using meds, now this is a belief, that using meds was a sign of weakness. And that's why, even though the medications, were viewed by the team and his mom as being helpful, he kept going off them. He thought he ought to be able to, do it on his own. And one time while he was off meds during one of these periods after hospitalization, he was standing in a store checkout line, and he began to hear distressing voices that were taunting him. And he began to pump his hand up and down, and, yelling back at the voices. And the store checkout clerk got really frightened and said, "Scary." And a coworker called the police, and police ended up bringing him to the hospital. And once again, he was involuntarily committed. And that's when I talked with him. And, he felt remorseful about having frightened in his own community, where what his aspiration was, what the value that he wanted to live by was helping. And so we talked about that the belief that meds was a sign of weakness were really clashing. They were out of harmony with his value of wanting to be a first responder and helping people. And I'll never forget it. I mean, as we were talking, he says, "I don't want to be a person that scares people. That's not what I want to be." Wow, what a moment. And so then we got to work on trying to find balance between his beliefs and the values he wants to live his life by. And it was a beautiful turning point for him in his recovery. It was all about him. And so this worksheet is a wonderful little worksheet where you can work with a person, with an individual, to think about their beliefs about psychiatric meds and bring them into harmony with the values I want to live by. Beliefs and values are not completely independent. There needs to be harmony between them. It's a great, hugely respectful way. Not magic, but something to think about. And then another thing I think that can really be helpful, the second way, is to work with folks to develop a message to their future self. So the person has a pattern of going off meds with bad results. There's a worksheet that can help the individual think through, when I use the medicine, here's what happens. When I go off the medicine, eventually, here's what happens. And based on that comparison, what message do I want to send to my future self? And take that message, personalize it, of course, and put it on yourself and share that little video with people you trust and give them permission. Hey, next time I'm getting ready to go off, at least play this video for me. It's me talking to me, right? So an example might be, so participants, Greg goes, I use the medicine, I've been able to work on my GED. And then Greg says, when I go off the medicine, eventually I go to the hospital. And his message to his future self can be, if I get GED, I make more money to buy a car. No money in the hospital, it's a dead end. He's going to say that into his own, and then make a time capsule of it. It's a very, very respectful technique that I think is really wonderful. Let's do another. Chantel. Chantel, like weed, it helps her chill, and it works better than your meds do. And she's got a self-medicating challenge. And there's no doubt that the self-medicating challenge is extremely prevalent in our time, mostly so, I think. And so, additionally, what's going to be our support strategy in working with people? Well, certainly all the good stuff like motivational interviewing, harm reduction strategies, IDT are key strategies. And I don't have any magical thing that's greater than that. But one thing that I find really important, and I hear it over and over again in first-person accounts, is the fact that if we shift focus from what's the matter with Chantel to what matters to Chantel as a team, it seems counterintuitive. We want to focus on the problem, which is the weed and abstinence, or at least harm reduction, and then we can get to what matters. But so many people say it's the reverse in terms of their own lived experience of their recovery, right? That the fact that I had some positive going on in my life that helped me connect the dots and say, when I'm using the weed, I can't do X, Y, and Z. Focusing on what matters seems to really matter too. So that's a great way to begin to convey hope to people too, is by focusing on what matters to them. So let me give you some direct quotes from people with experience of this turnaround. Here's what focusing on matters to me. Yes.
We're getting some lag in your audio.
You know, could be just bandwidth.
Yeah.
How bad?
It's sort of we're missing like about a third of your words. I don't know if you maybe switched off your video and tried for a bit. Maybe that would help.
Sure.
Yeah, we thought we'd kind of wait for a little bit to see if it got any better, but it's a little bit going in and
Sorry
out.
about that, guy.
It's all right.
Oh, video. All right. Is this better, Shanda?
Mm-hmm.
I'm sorry, you're not Shanda. That's the
It's
gal I'm
okay.
talking about.
Yeah, no, that's okay. Yeah, let's see. Keep talking for a minute. Just
Yeah, so I've been talking about the support strategy of shifting the focus from what's the matter with you to what matters to you.
it's still a little bit in and out. But we can do the best we can. I don't know if there's any way like to check your connection speed or refresh.
Hang on.
We have live captioning enabled too. It sounds like at least one person saying it hasn't been as bad for them. So we can troubleshoot a little bit and then we can come back
I'm gonna
and do the best we can.
I'm gonna get off Wi-Fi and just give me a sec. I'll get on let me turn off Wi-Fi. Okay, I'm still with you?
It seems better, Pat.
Okay, good. I've switched over cable instead of.
You
Okay, but
there?
I'm not screen sharing yet, right?
No, you're not.
Okay. So uh, okay, is this any better?
Yep. I think
Yes.
it is a little better. Yeah, you sound a little clearer.
Okay, good.
Thank you.
I'm sorry. Yep. So let's hear what it sounds like in terms of the lived experience of this. This is what focusing on what matters to me sounds like. People connect those dots. I want to focus on school and I want to be more productive throughout my day because I feel most of the time, whenever I get home, I just kind of sit on the couch for an hour or two or walk around listening to music and kind of get my mind off things. What led me to stopping was because work was going really well. And I would never go to work and smoke. I would smoke after work, away from the work area. I just thought that maybe if they drug tested me, I would have lost that job, and I really needed that job. I saw that I was not as effective or as effective as I could be communicating to people. My grades weren't as good, and I wasn't as quick in sports. And so I was also getting really fat, smoking a lot of weed and eating. So ever since then, I would go periodically, I would take breaks. And then every now and then, now I take a 4 to 6 month break from smoking weed. So the focus is not so much on I'm afraid of what I might lose, but rather it focuses on what I can do, right? The things that matter to me. I have one more to do before we take a quick break. This is Nadine. I was talking to her. I said, why did you stop the medicine, Nadine? She'd been in services a really long time. She said, I guess because I'm tired of medicine. Said, tell me about that. And she said, you just get burned out, Eventually you get burned out about your meds you got to take, especially when it's not helping you. You just get burned out. And I said, did you tell your doctor? And she said, no, because he just didn't take it. And she's experiencing the medication fatigue challenge. And med fatigue challenge can also sound like a human guinea pig. And I know you folks have heard these kind of things from people. All they do is experiment on me. I can't even remember how many meds I've been on. I'm sick of taking pills. None of these pills has ever really worked. When we hear these kinds of things that signal medication fatigue, we can ask key questions to learn more. Do you think you're on too much, too little, or just the right amount of medication? Ask people. And our essential strategies, of course, are deprescribing, which is not necessarily the same thing as discontinuing all medications. It might be, but it means identifying less essential meds that are ineffective, that sort of legacy meds that person may have been on, so we keep them on. Right? And encouraging the person to speak up via the Med Challenges worksheet. And people experiencing the medication fatigue challenge often are extremely hesitant to speak up. And they're hesitant because they're afraid of being given more medicine. That's been their experience. So it can be extraordinarily liberating to have the team say, we're concerned about this, and to invite the person to have a voice and a choice in their care. So that is the medication fatigue worksheet. And in it, basically, we help Nadine explore medication fatigue challenge. I'm sick of taking pills, etc. What are your words? What do you say to yourself? And then we can say, how does it feel to you? The meds are too heavy. I'm always tired. And then to be an effective self-advocate, what can you do? I'm going to talk to my peer specialist about this, and I'd like you to come to the meeting with me to support me next time I see a doctor. And then during the appointment, I'm going to ask my doctor about deprescribing, what meds might be unnecessary, what dosages can be lowered. In my own words, right? I think one of the things that can make a particular challenge very, very difficult for teams is that on the one hand, we might objectively be able to observe profound overmedication and polypharmacy, and very often a long history of polypharmacy. I'm talking about people on 2 and 3 antipsychotic medications and just an extraordinary smorgasbord of you name it. And part of where the team is coming is not to be cruel and evil, right, with that, but that the person probably has a very significant history of having returned to hospital, jail, or etc. And so the team, on the one hand, can be invested in the status quo and be really hesitant to want to, quote unquote, rock the boat. But I really do believe this is a moral dilemma for the team and needs to be addressed as such. And so, you know, it is challenging. But so I would say part of the med fatigue challenge can be not just Nadine, but for the whole team. And I'm hoping that by saying that out today, it gives you the opportunity to actually talk about this sometimes in your team. Are we at one of those points where we're afraid to rock the boat, even though we see objectively before us signs and symptoms of overmedication and polypharmacy? Okay, so let's take a pause and move to a discussion. I'm interested, if you guys have a million things to talk about, I of course do, and that is, how have you been looking or thinking about using the My Concern Self-Report? And how will you use it to help drive adoption of this new medication empowerment approach? And where have you or will you consider embedding it in your care pathway? Or any topic or question you'd like to ask.
Mm-hmm. Pat, we do have one question, if you'd like to answer that right now.
Yes.
And the question is, how do you distinguish med fatigue from tolerance?
Med fatigue from tolerance. Again, I look at objective signs, like is there in fact polypharmacy going on? Has there been a history of polypharmacy? And has there been a history of suboptimal response and multiple medication trials? That's how I understand individuals who are talking about this profound fatigue of taking these pills that don't really seem to help me. It's really difficult to take a new medication, mm-hmm. and you get your hopes up, and it's a roller coaster ride, right? Yeah. It's gonna help. The Clozaril's gonna, all right, and we do it, and then crash. It just doesn't do it. Doesn't seem to. So, yeah. Mm-hmm. I answer that.
Right. If people feel like answering Pat's questions in the chat, feel free to, and I can read out your responses. Or if there's other questions, pop it in the chat, in the Q&A box. I was wondering, Pat, you mentioned about how people talk about other kinds of, in the exploration challenge, when they're thinking about using other practices from cultural or complementary approaches. And if you could share an example of how teams could negotiate some of that.
Yeah. So, of course, we know people are doing this already anyway, right? And the negotiation, as far as I'm concerned, is that that's appropriate to bring to your team, to your primary clinician, to your psychiatric care provider, to your peer specialist, and let's explore this together. That this is a journey. And what I say to people about this, because I do all of this directly for people who use meds too. And I say the reason this is very important, and I use the sweat lodge example, and I say, sweat lodge is, amazing, yes. But this is very important to bring to your team. And you know why? Because maybe you're on lithium and you're in a sweat lodge on lithium, not a good thing, right? And so we never quite know how the medication we're using might interact with the other alternative, complementary cultural healing that we're interested in exploring. And also the idea that when we're doing an exploration, you can't always see everything that's going on with us. Sometimes you need that other set of eyes that says, man, now that you're doing the yoga and the meditation, I agree. I think we can come down on this anxiolytic. I think it could be, this is really, helping you chill. Wow. Yeah. So it's that other set of eyes. So.
Yeah, that's great. Kind of like the personal medicine metaphor that you've used before. And we have another question. Do you have any suggestions when an individual's medication challenge is around the belief that it is a way to control them and or poison them?
I don't have any magic on that one, kind of wish I did. And that can feel like such a catch-22 sometimes, because then you think sometimes if a person were, maybe if an antipsychotic were helpful, well, first, of course, always rule out that, in fact, you're not being poisoned. That's okay. Joining with the person to rule that out. But, I'm assuming that's done. And then it's like, okay, we can. What's tempting is to say, well, if they were on the antipsychotic, then maybe we'd get some traction and the false belief would be less compelling and make room for the medication to be experienced as effective. It's tough. Again, where I go with that kind of thing is focusing on what finding that personal motivation. I mean, trying to go head to head with a false belief is like, or a troublesome belief is really not going to get far. But like I think that if we can identify what matters to this person. I remember a guy I was working with, it was like, oh, he had a new girlfriend, and he was just really wanting to be with her. And at night he would stand with a baseball bat in front of his door, and his hands were on that baseball bat 12 hours, waiting at the door, so bad that in the morning he couldn't unclench them. What a way to live. And the girlfriend was not coming over in those conditions, right? And that was what the ticket was. He was willing to try because she was important enough to him to want to get together with her. That to me is the ticket. So yeah, tough one, very tough.
Right, but prioritizing what matters to the individual. And someone made a
comment. Can I say one other
thing
thing about that though? Because when you get into the poisoning, the meds thing and stuff, and so then very often the person will end up at the hospital, and then they'll be medicated over objection because, in fact, we know they're not being poisoned. And I get that, right? And then we see the person starting to have some relief from the intensity of that terror that I'm being poisoned. The belief, the thought can very much still be, it lacks the charge because the body is more subdued, right? And so then what happens is, then too often we just let it be and expect them to come out of the hospital and continue medicine, and they don't. We're surprised. We kind of didn't get in there and work. What is this like? We're not talking to people enough about the challenge of using this stuff. And so if we've got a moment of kind of clarity, this island of clarity, let's get in there and use that opportunity to talk, to get clear on what is this individual's challenge. Is that the time to do a message to myself? Me on video saying, I'm not being poisoned and I can actually read my Bible now. And it feels good. And I give you permission to show me this video if I off again, or I'm thinking about it. You know what I'm saying? Okay, I'll be quiet. I want to get to the other ones if I may. I mean, I hate to be, but I really want to finish giving you this. Okay. 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 Okay, so let's meet Jalissa. Therapist told me not to touch the computer when she left the room for a minute. I think she doesn't trust me because I'm Black, and that makes it hard to trust her. Of course, these are all real. I didn't, make these up. These are things I hear from people. Another one, my doctor profiled me. How am I supposed to work with someone who can't see me? My peer talks over me and hardly lets me say a word. I feel disrespected. Why would I want to talk to him? Right? So these are all implicit racial bias challenge. And when I think about my implicit racial bias, I find that an image of an iceberg is pretty helpful. It's a good analogy for thinking about my implicit racial bias. So at the tip of the iceberg is and I'm speaking of myself as a white woman. My intent and my training, this is conscious. And just like I was trained to approach each person as an individual and to treat people with respect. Number one thing, just like you are saying this way. But below the surface of the iceberg, of course, my implicit biases, and I have many, including my implicit automatic biases related to people of color. And there's a body of research that shows that our biases affect our judgment sometimes. And they also affect the ways that we interact with people of color. For instance, studies show that white clinicians sometimes underdiagnose depression in Black Americans, and we're more likely to diagnose Blacks with schizophrenia when compared to whites. And we also have studies that help us understand that implicit racial bias, our implicit racial bias, reduces person-centered communication, right? It can lead to higher rates of non-adherence with treatment recommendations. Our implicit racial biases influence our clinical behavior in other ways that are important. For instance, we tend to have shorter appointment times, and to show less empathy and exercise verbal dominance when meeting with certain BIPOC individuals. And importantly, there's an entire dimension of the lived experience of this challenge. So what's it like to be, for a person to be, a peer of mine, to be on the receiving end of my implicit automatic bias? And the research suggests that lived experience, that my implicit automatic bias can be a challenge for some people of color getting appropriate evidence-based finest services from me, from white clinicians. And that it can be more difficult to have confidence in my treatment recommendations because of that. And sometimes people don't even come to clinic because of this lack of trust that goes with feeling profiled or somehow being treated differently than other people using services who are white. So what do we, and by that I mean those of us who are white clinicians, what can we do personally about this? Because we don't want our biases to be a challenge for people getting the care that we've dedicated our lives to serving, right? Providing them with. So the good news is that we can take specific steps. We can become aware of our own implicit racial bias. And the tool I use, you may have other ones you can think of, but this is the one that I've found really eye-opening, is the implicit association test. It's free, it's online, and I was surprised. And I think many of my friends and colleagues have been surprised as well. So I personally took a couple of tests for different biases, and it really, the reason I recommend it in my experience is because it helped me admit completely to myself that I do have implicit negative associations with darker skin color. Not all the time, and I work on it, but it's there. And I, like so many of us, have been working on coming to terms with that. Now, once we bring into our consciousness the fact that we do have implicit racial biases, the second step is called perspective. And what this is about imagining ourselves in the other person's shoes and trying to see things from their point of view. And it's a cognitive component of empathy. I find that interesting. Perspective taking is a cognitive component of empathy. And studies show that as we practice perspective taking, this cognitive form of empathy, our bias and stereotyping begins to diminish. And that means that people feel more comfortable and can trust our treatment and care recommendations. And the step is this whole process of building partnership. So instead of saying things like you or they, you can say things like, since the medication didn't work out, our best course might be to, right? So I'm allied with you, our ally, I'm partnered with you. If we do this decisional balance worksheet together before the appointment, it might help you get the results you want with the doctor. It's about us, it's about we. So this idea of building practice. And of course, shared decision-making, that's what it's all about. Shared decision-making is all about building partnership. Okay, and now on to a really, I think, really profound and our final challenge. Oh, I forgot to mention, I do have a worksheet for implicit racial bias. The big idea here is that invite the person to reflect on their experience and invite them to develop a self-care plan. So if the person feels racially profiled, to use the close the front door framework. What did you observe? What did you think? I'm sorry, open the front door framework. What did you observe? What did you think? What did you feel? And what do you want to be different at your next appointment? This is a well-known way of managing microaggression for folks. So open the front door, and then a little self-care. What this hurts, it stings, it's difficult. What are you going to do? How can we support you? And how will I help you get the health care you deserve? Okay. This last challenge is, I think, really important. This is CC. She told me I'm a swimmer, like I made it to state finals, and snap. The next minute I wake up and I don't even recognize myself in the mirror. I gained weight, a lot of weight. I move slower. My pillow's wet from drooling at night. I couldn't swim for my team now if you paid me. They medicated me. I don't mind if they medicate what's supposed to be what they call mental illness, but don't medicate me. And this is what I call the redefining self challenge. And I think that it stems from the idea many people have in the general public that there is this thing that we call normal me. It's just me. It's normal me. It's regular old Pat. It's regular normal me. Not that I'm normal. This is how I know myself. This is how I know myself. And then I experienced this thing called psychosis or anxiety, whatever the mental health challenge is, right? And that feels definitely like a me that I'm used to, right? And I think most people assume that when we use an antipsychotic medicine, what happens is that I return back to normal me. Get back to yourself. You get back to, Pat. And parents anxiously ask this a lot. Will they be okay? Will they return? Yeah, they'll return to normal me. But I would say this is fundamentally an error. I don't believe it works this way. I think there's the me I knew before psychosis. There's the me with the psychosis. And then there's the me on medicine. And this me on medicine is very, very interesting because me on medicine is sort of third state. And it is not the same as normal me. Sometimes changes are small and even acceptable. Maybe it is dry mouth. Maybe it is a slow tremor. Maybe it's a feeling of being slower, of our thoughts not moving as quickly. Now, some people that might be very welcome, but others, I don't feel as sharp. I feel duller. I feel not as on, not as present, a little more out of it. I sleep more. I used to be a night owl. Now I don't stay up after 9 o'clock. That's different. That's not the me I know. Sometimes, as I say, these changes can be smaller, and some are maybe welcome of me on medicine, right? But sometimes the medicine and this experience, me on medicine, changes the things that make my life worth living, things that I'm passionate about, the things that matter to me, right? So an example might be that medicine has changed me in ways that I don't like. I am an artist. I am creative. And now my creativity is diminished. I want to be a graphic artist, a digital artist. I can't do that. I want to have my own YouTube channel and be, TikToker of the century, whatever your thing is. And I can't do it. I'm on that. And it's changed me in ways that are really important. And I don't like this new me, this me that I am. And so this is a very, very often a very subjective challenge, but it is really difficult to speak about. And it's really important for teams, peer specialists, psychiatric care providers, other clinicians to understand this phenomenon of coming to terms, rejecting, accepting, or modifying me on medicine. And it's not normal me. Even if the change is just dry mouth, well, if it's dry mouth, where now the saliva is congealing on the corner of my mouth, and I have that kind of bad breath that sometimes you can get when you take an antipsychotic, people that see me, my neighbor, my teacher, they can tell that I'm different, that I'm on medicine. I want to know what's going on here. And it confronts me with disclosure and all kinds of other unwanted or difficult challenges. This is a very subjective but very important challenge to understand. So I think it raises the question of who am I now that I use medication? It can include changes to my embodied self, which I've described, changes to the emotional and spiritual self that I know, changes to beliefs about who I am. So maybe I believe again that I'm a person who, it should be strong, but I'm not strong. But now I'm using meds. So what does it mean that I use them? And so on. Redefining self-challenge. Will I change my understanding of my lived experience, my embodied self, or not? Do I reject this self and say, this isn't me, and I won't be this? That's what Cece's dealing with. So in order to get at this challenge with people, it's very important, once again, to get way proactive around this thing. And this, by the way, is a huge challenge for young people with their psychosis, enormous. They're just coming into self, into identity. And then we get medicated and wow, who am I now that I take medicine? What does this mean, right? We can get ahead of the curve here. We can get upstream and ask people, are you concerned about how meds have changed you? What a beautiful thing to ask somebody. Are there any ways that meds make things worse for you rather than better? Are there ways meds change your beliefs about yourself? These are beautiful, compassionate questions that we can ask folks. And just to reinforce this for a minute, I want to take you out further on the lifespan, okay? Because I do a lot of talking with peers and friends who use meds further 10 years, 15 years, 20 years out. All of a sudden, what people are willing to let go of, what they grieve having lost by using meds. We think people only gain stuff by taking meds, but there are losses. Listen to this. So this is Max. I'll never forget it. Oh, by the way, Max had been on antipsychotics for many, many years, and he went on as a young person, and now he was into his 30s. And he says, I'll never forget it. I was driving, and I was a little sad, but it was different, richer and deeper, more visceral. And I said, why is this happening? This richness, this more visceral sadness. And I realized that the titration down of less medication, I was really experiencing a piece of me that was deadened for 10 years. And I started crying, not because of the sad moment, but because it was a piece of me that was deadened for 10 years and that I never thought I'd get back. And I almost forgot what it was like to experience it. What do you say to that? Not only having a piece of life ripped or pulled from you, but then forgetting what it's like to even experience it. And I call this redefining self through that rear mirror. This is a challenge, my friend. This is hard stuff. We think people only gain by taking meds. We hope they gain. Many of us do. But there can also be really sad parts about it, this change in how I experience myself. Here's another one. This is Dan. Still, I sometimes wonder if my psychosis would have been a journey towards spiritual awakening. As I'm older now, the meds are reduced in effectiveness, and I once again hear voices and experience my emotions more colorfully. Could this be my second chance at my spiritual journey? And through the rearview mirror. So you won't be surprised that I'm going to encourage us to get upstream with folks and also offer a worksheet for this. And I call it Psychiatric Medicine and Me. And the beauty of psychiatric medicine and me is that I get a chance to tell my clinician, to tell my psychiatric care provider, to tell my team, me, I'm a night owl. I'm a friendly person. I'm quiet. I never talk. Everyone in my family talks too much. You come to our dinner table, whatever your thing is about you, describe you. What were my hopes about what meds could do for me? In my own words. What are my concerns about how meds have changed me or might change me, right? And then how I'm going to share my description of me and how have meds have changed me with my team. So beautiful honoring of the individual and the challenge, significant challenge of using meds when I experienced them as having affected my sense of identity and self. So you get to stop now. And again, I'm interested in your thoughts about this approach that I'm now calling medication empowerment, and the ideas you have about how this stuff could become more useful to you, or anything else you'd like to talk about.
Pat, I think there's a question and a couple of comments that have come into the chat that I think really relate to the last part of your presentation, in terms of, and also the question about how to make the material more useful. One person says, is there a sheet that outlines some of the positive things that may result from coming off of medication? The checklist I saw seems to only outline negative outcomes. And is there anything to address the fact that most prescribers may not have been trained in the nuances of deprescribing? That is, how quickly or slow people withdraw from medication as a consideration?
I mean, these are great points. Maybe we'll just do one at a time. Can you, let's start with the second one, the deprescribing piece. Right? Mm-hmm. So on the deprescribing thing, I mean, I think the issue is less that, I mean, if people want training on deprescribing, if you don't have it, I don't think it's particularly like rocket science. I mean, medically trained people or trained to prescribe can also think through how to systematically deprescribe, right? We don't do it all at once and on and on. There are great books. One came out of Yale just a couple of years ago on deprescribing psychiatry. So yeah, I think it's not rocket science to get that know-how if you don't have it already. I think the thing is finding the will to do it. And again, I think the dilemma is what the teams struggle with is rocking the boat. And I think it has an ethical dimension to it. We're afraid if we rock the boat, if we deprescribe even a single med, that who knows? Maybe it was prescribed many years ago, but they haven't been back to the hospital since, and so we stay on it. And yeah. You can, in other words, I don't think this is an issue of real. I mean, it's not a subjective issue. You can see polypharmacy in a chart, and you can see sometimes that it's gone on for many years. No one person's exhausted. Mm-hmm. So I think it's an ethical issue, But if it's done systematically with support, I think it works. It can happen.
Right.
And can you repeat the first thing?
It was just a comment about the sheet that outlines some of the positive things that may result from coming off of medication. So that the person is saying that the checklist I saw seems to only outline negative outcomes. I think she's referring to one of the earlier worksheets.
Yeah. I think, that coming off medications, I think the important part there, what we talked about the last time, was that it's easy to come off medications. The hard part is coming off medications and staying well. And that, of course, there can be wonderful things about coming off meds, but I think that I don't think it's our role as non-medical staff to be encouraging people to come off meds. Although sometimes it's interesting because psychiatric care providers find themselves wanting to reduce meds, and sometimes people say, I don't want to rock the boat. Like it's just the way it is right now, thank you. So no, there can be wonderful things to coming off meds. It can be a wonderful process, but there are really important things we need to do in that are listed in that checklist about coming off in order to do so successfully. And that's what that worksheet is really all about. It's not really saying come off, go back on. It's saying, hey, this is a process, and do it with your team and have a plan and do it collaboratively. And that just because we make a reduction and we decide to plateau for a while at that dose, doesn't mean it's a failure. It's just part of the process. Things like that, and how to take care of ourselves when we're starting to come off. That we might feel more intense emotions, which may be startling and new, as you could see from that rearview mirror stuff we just saw. So I don't think I was painting a bleak picture of coming off meds. It was more like, hey, heads up,
Right. Right. We have comment about how useful this talk is, and somebody's sharing about their own struggles with fear of rocking the boat in their own lives, and sort of see the system-wide structures around the paradigm of biological psychiatry and thinking about other models of wellness. So there's appreciation for your talk and talking about some of these alternatives. Someone gives another strategy of a PDF is a gift to share with a person. Looking up the medication, encouraging a talk with the pharmacist is useful, that anyone can do. And then someone asks, any tips on communicating with a psychiatrist when the person goes to a provider wanting meds for one issue or one set of symptoms, and the provider wants to focus on another diagnosis or issue or symptom? I'm thinking of our people with multiple diagnoses and my own experience and unique challenges of self-advocacy there.
I wish I had an example, actually. Like, so you want to go in one mental health challenge and get treatment for that without a different mental health challenge being addressed?
Yes, the provider is focusing on something the person does not want to focus on.
Yeah, so the answer is no. We're going to focus on what I need to focus on. I got my personal medicine. I know how to work with the anxiety. I need help with the depression or whatever, you think it might be. So no, what's interesting to me is in a scenario like that, that's actually a great example, a great point. And I probably would start with the power statement. Now you guys have a power statement, my goal for treatment. What is my goal for treatment? And I want you to help me find a medicine that will blank so that I can blank. I want you to help me find a medicine that will help me concentrate so that I can go back to school. And that's my goal for treatment. And that's what treatment focuses on. Don't treat the challenge, treat the disease. Treat me, it's me. That's what we started by saying. I would keep that front and center and use a power statement in that instance. Not a passive subject, not a passive object on which you act. I am a partner in my care. I co-create the care with you.
Right. And I think that there were a couple of comments about the sort of control dynamic that sometimes gets created within these encounters. And I think that what you're providing is an antidote to that kind of control dynamic of controlling.
Yeah. Mm-hmm. That's a beautiful point. Yeah. Well, that's why I call it medication empowerment. And I'm getting, it's about me getting empowered to have a voice and a choice in my care. Mm-hmm. Because ultimately, that's what psychiatric care providers to do. They weren't trained to treat diseases. They were trained to treat human. That's where we find joy in the work. Okay. Well, one thing I want to let you know is that I've put all this stuff together as a whole big series of animated videos that you can use directly with individuals, and then there are e-learning courses for this, and I'll be rolling those out. And a whole e-learning series for peer supporters on this. And we'll be rolling that out soon. And, see how it goes.
Great. Yeah. And if we're kind of already getting your emails on that, or if people want to get access to that, Pat, it's on your website?
.com.
Okay, great. Excellent. Well, thank you so much. I'm sorry for all the technical stuff that we had to kind of work through. Appreciate you bearing with us, Pat, for you to be willing to troubleshoot with us.
Maria, did it get better?
A little bit. It was still lagging a little bit, but I think it got a little bit better. And I was comparing notes with some other folks who actually thought it was fine the whole time. So I don't think you need to worry. You can actually have yourself on video if you want to say goodbye to folks. I don't think there's any harm in that right now. And it just to, say we've gotten lots of positive comments in the chat as well. And just people really excited about the work that you're doing and how much this resonates for them. So I think I've said this before, but I think this is now at least the third time that I've seen this part 1, part 2 series. So I've seen six times now you present on this, and every time I learn something new. So I just appreciate so much the opportunity to learn from you and to continue to share your resources. And what I love about it is you're always innovating within the resources you have, including the title, which is we've got the old version, and you've updated to better reflect more the empowerment piece. So appreciate that as well. I'm going to go ahead and share my screen going forward here just for folks. Can you see okay the slides? All right. And let's see here. I think there we go. So if anyone has, it's not letting me advance here. Hold on. For some reason. I'll just tell you all. So on our website, you'll see in the chat, we'll put it back in here. Several folks were just wanting to know kind of where the slides and the recordings will be. You'll be getting those in a couple of weeks. There's also the website it's in the chat, all of the materials and handouts that Pat shared, including the part 1 of the series, as well as a couple of fantastic webinars focusing on recovery-oriented care and person-centered approaches, personal medicine earlier within this series. So this is now the 4th webinar that we've done. You can also sign up to get our newsletter going forward. And we would just, again, love to get your feedback on today's webinar to guide future approaches. We're still going to hopefully have more opportunities in the next year to work with Pat, and we need to schedule time soon, Pat, to talk about that. And have a wonderful summer, everyone. Be safe. I hope warm, but not too warm, and enjoy the rest of your time this summer. Thanks again for joining us today.